Good afternoon, everyone. Good afternoon, everyone. Center of Excellence at Bowring and Lady Curzon Hospital, Bangalore. Welcomes all the participants for today's RDLS session. Today's topic is Advanced Disease Management in PLHIV, and the speaker is Dr. Mohan CN. Dr. Mohan CN, sir, is an assistant professor with the Department of General Medicine at Bowring and Lady Curzon Hospitals, Bangalore. He also serves as a deputy program director for the Center of Excellence in HIV care at the same institution. Sir is an active member of the API Karnataka chapter, the Indian Medical Association, and API India. He has authored several national and international publications and has presented his work at multiple national conferences. We welcome you, sir, for today's session and request you to start the session.
So good afternoon, everyone. Myself, Dr. Mohan, Assistant Professor in the Department of General Medicine. So today I'll be talking about advanced disease management in patient living with HIV. So today's topic, and if everyone is okay, then I'll be starting my session. All right. So what are the session objectives? So by the end of the session, what specific learning objectives do we have to know? So by the end of the session, the participant should know what is advanced HIV disease in adults and children. So advanced HIV disease andre ಏನು ಅಂತ ಎಲ್ಲರಿಗೂ ಗೊತ್ತಿರಬೇಕು. And what is the need? ಯಾಕೆ advanced disease HIV disease management, why everybody should know, all ART centers should know, so that you'll be able to tell. And ಇದ್ರದ್ದು components ಏನು? Advanced HIV disease management components. What are the components of this advanced HIV disease management? So I'll be briefing through all these headings. So if any doubts will be there, will be taken up at the end of the session. So why are we talking about advanced HIV disease? So ಈ ಗ್ರಾಫ್ ನೀವು ಗಮನಿಸ್ತಾ ಇದ್ರೆ, so look at the arrow mark. So what has happened to HIV or AIDS related deaths? So AIDS related death 1990 ಇಂದ ಗಮನಿಸಿದ್ರೆ, so somewhere 2005 ಅಲ್ಲಿ the mortality or deaths occurring due to AIDS disease had spiked up. So what the target was in 2020 was to reduce the AIDS related death to less than 5 lakh. So but ಏನಾಗಿದೆ 2020 ಅಲ್ಲೂ despite all this, the deaths that were reported were more than 6,80,000 even in 2020. So ನಾವು ಈ target ನ miss ಮಾಡಿದೀವಿ, and also you can see the graph, it is plateaued and it is not coming down. So ideally we should have a downward trend in mortality, but it is just plateaued there, so it is not coming down. So that is why we should all know everything about advanced HIV disease. So why early detection is important? ನಾವು ಯಾಕೆ ತುಂಬ ಬೇಗ HIV ನ ಡಿಟೆಕ್ಟ್ ಮಾಡಬೇಕು? So ಮುಂಚೆ there was concept that very low CD4 count, so we had to initiate HIV therapy. So in 1995 to 2005, the evidence showed that ART na CD4 less than 200 ಇರೋರು ಮಾತ್ರ ಇನಿಷಿಯೇಟ್ ಮಾಡ್ತಿದ್ವಿ, because it used to reduce AIDS mortality, AIDS related death ಕಡಿಮೆ ಆಗ್ತಿತ್ತು, ಮತ್ತೆ opportunistic infection in AIDS patient was less. Then further evidence in between 2005 and 2010 ಏನು ತೋರಿಸ್ತು ಅಂದ್ರೆ, we can initiate ART in patients with CD4 less than 350. But what is the recent studies or recent trials, what they have shown, that is the Temprano study and the START study, ART ಏನಾದರೂ more than 500 cells ಇರೋರಿಗೆ ನಾವು ಏನಾದರೂ ಇನಿಷಿಯೇಟ್ ಮಾಡಿದ್ರೆ, so HIV morbidity, disease progression, everything was reduced, and also any serious adverse effect also came down. So basically since 2016 ನಾವೆಲ್ಲ ART centers ಏನು ಫಾಲೋ ಮಾಡ್ತಿದೀವಿ ಅಂದ್ರೆ, anybody who was diagnosed with HIV, we are starting them on ART. So the evidence that we got was in 2015 by the landmark trials, Temprano trial and START trial. ಸೊ ಅದಾದ್ಮೇಲಿಂದ 2016 ಆದ್ಮೇಲಿಂದ ವಿ ಆರ್ ಸ್ಟಾರ್ಟಿಂಗ್ ART ಫಾರ್ ಎವ್ರಿಬಡಿ ಇರೆಸ್ಪೆಕ್ಟಿವ್ ಆಫ್ ದ CD4 ಕೌಂಟ್. ಸೊ ವೈ ಅರ್ಲಿ ಡಿಟೆಕ್ಷನ್ ಇಸ್ ಇಂಪಾರ್ಟೆಂಟ್? ಸೊ ಅರ್ಲಿ ಡಿಟೆಕ್ಷನ್ ಯಾಕೆ ಮಾಡಬೇಕು? ಸೊ ಮೇನ್ಲಿ ಟು say if the patient present late in the stage of HIV disease, so they might have low CD4 count. So late ಆಗಿ ನಾವು ಸ್ಟಾರ್ಟ್ ಮಾಡಕ್ ಹೋದ್ರೆ ಆಲ್ರೆಡಿ CD4 ಕೌಂಟ್ ಡಿಕ್ಲೈನ್ ಆಗಿರುತ್ತೆ and they might have suffered from severe opportunistic infection. So ಅವರಲ್ಲಿ opportunistic infections detect ಆಗಿರುತ್ತೆ and when you start late there'll be a suboptimal response to ART. ನಾವು ಏನು ART ಕೊಡ್ತೀವಿ ಅದು ರೆಸ್ಪಾನ್ಸ್ will be less and also poor prognosis and increased mortality. So the prognosis ಅದರಿಂದ ನಮಗೆ ಹೆಲ್ಪ್ ಆಗೋದು ತುಂಬ ಕಡಿಮೆ ಇರುತ್ತೆ ಮತ್ತೆ ಮಾರ್ಟಾಲಿಟಿ ಅಂದರೆ ಡೆತ್ಸು ಜಾಸ್ತಿ ಆಗುತ್ತೆ. So when you start late ART, what happens? The person would have already transmitted the infection to spouse or sexual partner or infant by mother to child transmission. So that is why the focus now is on early detection. Now ಬೇಗ ಡಿಟೆಕ್ಟ್ ಮಾಡಲೇಬೇಕು, ಬೇಗ ಡಿಟೆಕ್ಟ್ ಮಾಡಿ ಟ್ರೀಟ್ ಮಾಡಬೇಕು. So if you compare in patients ಯಾರಿಗೆ ಅಡ್ವಾನ್ಸ್ಡ್ ಇಮ್ಯುನೋಸಪ್ರೆಷನ್ ಆಗಿರುತ್ತೆ ಅಂದರೆ CD4 less than 200 at initiation of therapy to patients whose CD4 count is more than 200 at initiation of ART treatment, mortality is 50% higher. So 50% ಜಾಸ್ತಿ in individuals who had CD4 less than 200. So that's why ART initiation early is important. Not it won't benefit if you start if the CD4 count is already dropped and the patient has already had advanced immunosuppression. So what is happening in the present scenario is if we look at the graph, ಈ graph ನ observe ಮಾಡಿದ್ರೆ orange line is CD4, orange color is CD4 less than 100 at the time of initiation of ART. So CD4 ಯಾರು ಕಡಿಮೆ ಇರುತ್ತೆ ಅವ್ರನ್ನ ಆರೆಂಜ್ ಗ್ರಾಫ್ ಪರ್ಸೆಂಟೇಜ್ ಅಲ್ಲಿ ತೋರಿಸಿದ್ದಾರೆ. ಬ್ಲೂ ಗ್ರಾಫ್ ಪರ್ಸೆಂಟೇಜ್ CD4 more than 100. Okay, so this is an African data where they have studied the Africa elite, they have studied over years. So in whom they are starting ART with CD4 less than 100, in whom starting with CD4 more than 100. So and they have observed that as high as 70% ಜನಗಳಲ್ಲಿ they are starting it with CD4 less than 100. That means they are starting it late, or the people that they are coming to the ART center will be late in the course of the disease. So they are starting it late. That means the CD4 has already dropped. So it is seen in as high as 70% of incidences. So if you can see 2013, 2014, 2015, 2016 data ನೋಡಿದ್ರೆ ನೀವು, ಸೊ CD4 ಯಾರಿಗೆ ಲೆಸ್ ದೆನ್ 100 ಇರುತ್ತೆ, ಸೊ ಆ ಟೈಮಲ್ಲಿ ಇನಿಷಿಯೇಷನ್ ಆಗ್ತಾ ಇದೆ ART. ಸೊ ದಟ್ ಮೀನ್ಸ್ ಇಟ್ ಇಸ್ ಲೇಟ್. So what has happened to Indian? So Indian scenario, if you understand, so ನಮಗೆ ಗೊತ್ತಿರೋ ಹಾಗೆ there are 2.3 million individuals living with HIV and the prevalence is 0.22%. That's the national prevalence. So recent estimate from middle income settings suggests that 30 to 40% of patients living with HIV had a CD4 count of less than 200 at the time of initiation of ART. 20% have CD4 less than 100 at the time of initiation of ART. ಸೊ ನೀವು ನಿಮ್ಮ ಪೇಷಂಟ್ಸ್ ಅಲ್ಲೂ ಗಮನಿಸಿದ್ರೆ ನೀವು ART ಇನಿಷಿಯೇಷನ್ ಮಾಡೋ ಅಷ್ಟರಲ್ಲಿ CD4 ಮೆಜಾರಿಟಿ ಅಂದರೆ 30 to 40% ಪೀಪಲ್ ಅಲ್ಲಿ ಆಲ್ರೆಡಿ ಲೆಸ್ ದೆನ್ 200 ಇರುತ್ತೆ. In that 20% also has a CD4 of less than 100 at the time of initiation of ART, which is quite significant. So what is the burden of advanced HIV disease in India? So now 2005 data ಇಂದ 2018 ಡೇಟಾ ಗಮನಿಸಿದ್ರೆ ಈ ಗ್ರಾಫ್ ಅಲ್ಲಿ ನೀವು ಮೀಡಿಯನ್ CD4 ಕೌಂಟ್ ಅಂದ್ರೆ ART ಸೆಂಟರ್ಗೆ ಅವ್ರು ಬಂದು ರಿಜಿಸ್ಟರ್ ಮಾಡಿಸಿದಾಗ ಅವ್ರದ್ದು ಮೀಡಿಯನ್ CD4 ಕೌಂಟ್ ಆವರೇಜ್ ಪಾಪ್ಯುಲೇಷನ್ ತಗೊಂಡಾಗ ಎಷ್ಟಿರುತ್ತೆ ಅನ್ನೋದನ್ನ ಗಮನಿಸ್ಬೋದು. ಸೊ ಇನ್ 2005 it was around 170. So as the years, that is in 2018 ಅಲ್ಲಿ the median CD4 count is 275. So that was the median CD4 count that was observed when they are registering to the ART center. So that is also quite significant. So let us see the baseline CD4 distribution in India according to 2019 data. ಸೊ ನಾವು ART ಸೆಂಟರ್ಗೆ ಬಂದಾಗ ಅವ್ರಿಗೆ CD4 ಟೆಸ್ಟ್ ಮಾಡಿದಾಗ ಸೊ ವಾಟ್ ಈಸ್ ದ ಡಿಸ್ಟ್ರಿಬ್ಯೂಷನ್, ಎಷ್ಟು ಪರ್ಸೆಂಟ್ ಜನಕ್ಕೆ CD4 ಲೆಸ್ ದೆನ್ 200 ಇರುತ್ತೆ, ಎಷ್ಟು ಜನಕ್ಕೆ 200 to 350 ಇರುತ್ತೆ, 350 to 500 ಎಷ್ಟು ಜನಕ್ಕೆ ಇರುತ್ತೆ, ಮೋರ್ ದೆನ್ 500 ಎಷ್ಟು ಜನಕ್ಕೆ ಇರುತ್ತೆ. So if you see that CD4 count less than 100, significantly higher population, 35% of population, 35% ಅಂದರೆ 100 ಜನದಲ್ಲಿ 35 ಪೀಪಲ್ಗೆ CD4 at the time of initiation of ART will be less than 200. So it's a significant population number with CD4 count of less than 200 at the initiation of ART. So 200 to 350, 26%, 350 to 499, 18%, more than 500, only 21% had a baseline CD4 count of more than 500 at the initiation of treatment. So again, this highlights that they are presenting late. So they are presenting in an advanced disease stage. So what is advanced HIV disease? So ಯಾರಿಗೆ ನಾವು advanced HIV ಇದೆ ಅಂತ we will consider. So the definition is as follows. For adults and adolescent and children older than 5 years, advanced HIV is defined as CD4 less than 200 cells per millimeter cube or WHO stage 3 or stage 4 event. Includes both ART naive individuals and those who interrupt treatment and return to care. So adult population ತಗೊಂಡ್ರೆ or children more than 5 years ಅಲ್ಲಿ ತಗೊಂಡ್ರೆ ಯಾರಿಗೆ CD4 ಕೌಂಟು ಲೆಸ್ ದೆನ್ 200 ಇರುತ್ತೆ ಆರ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಅಲ್ಲಿ WHO stage 3 stage 4 infections if or any event if they have had, then you should consider them as advanced HIV disease patients. So this includes before starting ART as well as individuals who will be on ART but they would have stopped for some reason. So our time ನೀವು CD4 measure ಮಾಡಿದಾಗ್ಲೂ if you find this observation, then they will be also considered as advanced HIV disease. So when it comes to children, so all younger children less than 5 years who are not already receiving ART and clinically stable with HIV are considered as, so children only there is no cutoff for CD4 count. Any child who is less than 5 years and not receiving ART is considered as advanced HIV disease. So ಇದರಲ್ಲಿ ನಿಮ್ಗೆ ಏನು ಇಂಪಾರ್ಟೆಂಟ್ ಅಂದರೆ ಬೇಸ್ಲೈನ್ CD4 count. So baseline CD4 count is the key in defining advanced HIV disease. So ಬಂದಾಗ ನಾವೇನು CD4 count ಮಾಡ್ತೀವಿ, that is very very crucial. So that's why you should consider CD4 count as an important marker. So why mortality is more in advanced disease? Mortality ಯಾಕೆ ಜಾಸ್ತಿ ಅಡ್ವಾನ್ಸ್ಡ್ HIV ಅಂತ ನಾವು ಡಿಫೈನ್ ಮಾಡಿದ್ಮೇಲೆ ಅವರಲ್ಲಿ ಯಾಕೆ ನಾವು ತುಂಬಾ ಡೆತ್ಸ್ಗಳನ್ನ ನೋಡ್ತಾ ಇದೀವಿ? ಫಸ್ಟ್ ಥಿಂಗ್ ಇಸ್ ಬಿಕಾಸ್ ಆಫ್ ಇನ್ಕ್ರೀಸ್ ರಿಸ್ಕ್ ಆಫ್ ಆಪರ್ಚುನಿಸ್ಟಿಕ್ ಇನ್ಫೆಕ್ಷನ್ಸ್ ಅವರಲ್ಲಿ ಜಾಸ್ತಿ, ಐರಿಸ್ ಕಾಂಪೊನೆಂಟ್ ಜಾಸ್ತಿ, ಏಡ್ಸ್ ರಿಲೇಟೆಡ್ ಅಂಡ್ ನಾನ್ ಏಡ್ಸ್ ರಿಲೇಟೆಡ್ ಕೋಮಾರ್ಬಿಡಿಟೀಸು ಇವರಲ್ಲಿ ಜಾಸ್ತಿ. So and also they will need frequent monitoring, and because of this there is economic burden to patient living with HIV and health system also. So this reasons in the advanced disease alliroge mortality is more compared to other individuals. See, if you can see this graph, ಇಲ್ಲಿ ಎರಡು ತರ ಪಾಪ್ಯುಲೇಷನ್ ಡಿವೈಡ್ ಮಾಡಿದ್ದಾರೆ, ಒಂದು ಅಡಲ್ಟ್ಸ್ ಇನ್ನೊಂದು ಚಿಲ್ಡ್ರನ್. Okay, so what they have found is this side is mortality, so 57% higher mortality, whereas in children it is 56% higher mortality in individuals with advanced HIV disease. So mortality could be ಯಾವ್ದ್ರಿಂದ ಸಾಯ್ಬೋದು, either it could be AIDS related, it could be bacterial infection, it could be neurological infection, it could be respiratory infection or liver related infection, both in adults and children. In children extra that would be is malnutrition and wastage. So the mortality is higher among individuals with advanced HIV disease because of following reasons. It could be AIDS related, bacterial, neurological, respiratory and liver infections, in children because of same along with malnutrition wasting. So e graph, if you see, age-related events are more frequent cause of mortality. Say if you can see, age-related tuberculosis in adult is 27%, and susceptibility for bacterial infection is also more. And you can also see that opportunistic infections are also more in these patients. So this is again a tabular representation of causes of mortality in advanced HIV disease. So adults early tuberculosis, severe bacterial infection, cryptococcal meningitis, toxoplasmosis, and PCP. Children early tuberculosis, severe bacterial infection, PCP, diarrhea, and malnutrition, wasting. So these are all the causes for mortality, common and more prevalent causes for mortality. So what is this package of advanced HIV disease management? Now, Ivaga, we saw what is the definition of advanced HIV disease and why advanced HIV disease is taken as a separate entity, because mortality is more among these patients. And when you're starting ART, their baseline CD4 is only less. So, what is this management package of advanced HIV disease management? This package of differentiated care includes, so ಏನೇನು ಬರುತ್ತೆ ಅಡ್ವಾನ್ಸ್ಡ್ ಎಚ್ ಐ ವಿ ಡಿಸೀಸ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಅಲ್ಲಿ? ಒಂದು, ಸ್ಕ್ರೀನಿಂಗ್, ಟ್ರೀಟ್ಮೆಂಟ್ ಅಂಡ್ ಪ್ರೊಫಿಲಾಕ್ಸಿಸ್ ಮೇಜರ್ ಆಪರ್ಚುನಿಸ್ಟಿಕ್ ಇನ್ಫೆಕ್ಷನ್, rapid ART initiation, intensified adherence support. So, what is the aim of this package? It is to reduce morbidity, mortality, and among patients with advanced disease. The benefit of these interventions have been well demonstrated in the reality and the REMSTAR trials. So, by doing this, mortality, morbidity ಕಡಿಮೆ ಮಾಡ್ಬೋದು. ಅದನ್ನ ನಮಗೆ ಎವಿಡೆನ್ಸ್ ಬೇಸ್ಡ್ ರಿಯಾಲಿಟಿ ಅಂಡ್ ರೆಮ್ಸ್ಟಾರ್ ಟ್ರಯಲ್ಸ್ ಅಲ್ಲೂ ನೋಡಿದ್ದೀವಿ. So, what is the package of care in advanced disease management? One is screening for active TB and prompt initiation of anti-TB treatment or isoniazid prophylaxis therapy as indicated. Second, so every patient whom you define that this person is a case of advanced HIV disease. So first thing is screen them for active TB. Any symptoms of TB or any evidence of TB, start anti-TB treatment, or no symptoms, you can start IPT prophylaxis as indicated, which I will be discussing much later. And also do a systematic screening for cryptococcal antigen, fluconazole preemptive therapy for individuals with cryptococcal antigen positive, people without evidence of meningitis. So although it is not screening is not included in the national program, cryptococcal antigen screening is one of the component of advanced disease management. So ನಾವು ಬಂದವ್ರಿಗೆ ಮೆನಿಂಜೈಟಿಸ್ ಇಲ್ಲ ಅಂದ್ರೂ CD4 ಕಡಿಮೆ ಇದ್ದಾಗ ಕ್ರಿಪ್ಟೋಕಾಕಲ್ ಆಂಟಿಜನ್ ಟೆಸ್ಟ್ ಮಾಡಿದಾಗ ಪಾಸಿಟಿವ್ ಬಂದರೆ ಅವ್ರಿಗೆ ಫ್ಲೂಕನೋಸೋಲ್ ಇನಿಸಿಯೇಷನ್ ಥೆರಪಿ ಮಾಡ್ಬೋದು. Then screening for cotrimazole prophylaxis. Identify individuals who are eligible for cotrimazole prophylaxis and start treatment. So rapid initiation of ART. So once the risk of iris is assessed, so ART urally ಬೇಗ initiate ಮಾಡಬೇಕು, and also adapt adherence support and intensive follow up. So you should always counsel them for adherence and also follow them up intensively. Okay, so this is the package that we have. So as I've already said, screening and diagnosis is very important. So ಏನು ಸ್ಕ್ರೀನ್ ಮಾಡಬೇಕು ಇವರಲ್ಲಿ ಅಂದರೆ ಮೇನ್ ಆಗಿ TB and also cryptococcal meningitis. So first thing is, how do we screen for TB? How do you screen? Generally in your ART clinics ನೀವು already ಮಾಡ್ತಾ ಇರ್ತೀರಾ. 4S TB screening is what we clinically screen. ಅಂದ್ರೆ patient ನ ಕೇಳಿ ಮಾಡೋದು. So is whom do we all for who all patients do we do this? We should be doing this irrespective of their CD4 count. ಎಷ್ಟೇ CD4 count ಇದ್ರೂ any patient with HIV coming to your clinic, screen them for 4S TB screening. So you can do it for both children and adults. And also you can send sample for sputum CBNAT or TrueNAT as the first test for TB diagnosis among patients with symptoms. So ನೀವು ಸ್ಕ್ರೀನ್ ಮಾಡಿದಾಗ ಯಾರಿಗಾರು symptoms ಕಂಡು ಬಂದ್ರೆ you can send the sputum for CBNAT. And there is something called TB lateral flow lipoamino mannin test, which is done in individuals to assist the diagnosis of active TB in HIV positive individuals who are seriously ill with symptoms and signs of TB or irrespective of signs and symptoms of TB. So, in whom do we employ this test is CD4 count less than 200 or any seriously ill patient having any of the danger signs, that is respiratory rate more than 30, heart rate more than 120, or unable to walk unaided. However, TB lateral flow urine liposaminomannan test is not available in the national program. Okay, this you can do it for adults and children as well. So cryptococcal antigen screening. So this is done for individuals with CD4 count less than 200, mainly for the adults and adolescents and not for children. So screeningly we have TB screening, TB lateral flow LAM screening, and cryptococcal antigen screening. We should notice two things here. TB lateral flow LAM screening and cryptococcal antigen screening is currently not included in the program. Okay, in our national program it is not included. So that is about screening. Any patient coming to your ART clinic, screen them for TB. If symptomatic, send sample for sputum CB9. So then we will talk about the prophylaxis and preemptive treatment. So what all prophylaxis do we have in the national program? So one is cotrimoxazole prophylaxis. So ಯಾರಿಗೆ ಕೊಡಬೇಕು cotrimoxazole prophylaxis ಅಂದ್ರೆ if CD4 count is less than 350 cells per millimeter cube or if there is any clinical stage 3 stage 4 disease. It is applicable for both adults and adolescents and children. And also TB preventive therapy. So any CD4 count, adults and adolescent and children. So prophylaxis ನೀವು ಯಾರಿಗೆ ಕೊಡಬೇಕು ಅಂದ್ರೆ ಯಾರಿಗೆ symptoms ಇರಲ್ಲ, ಯಾರಿಗೆ there is no evidence of active TB. In them you should give TB prophylaxis therapy. Fluconazole preemptive therapy for crack positive people without evidence of meningitis. ಸೊ ಇದು ಯಾರಿಗೆ ಅಂದರೆ ನಾವು ಏನಾದರೂ ಪೇಷಂಟ್ಸಲ್ಲಿ ಕ್ರಿಪ್ಟೋಕಾಕಲ್ ಆಂಟಿಜನ್ ಸ್ಕ್ರೀನಿಂಗ್ ಮಾಡಿ ಅವರು ಪಾಸಿಟಿವ್ ಬಂದು there is no evidence of meningitis. So ಆ ಥರ ಪೇಷಂಟ್ಸಲ್ಲಿ you can start fluconazole prophylaxis. So under prophylaxis we have cotrimoxazole prophylaxis, TB prophylaxis and fluconazole prophylaxis. So rapid ART initiation. So you should always think that these patients should be given priority and you should initiate ART as early as possible, irrespective of their CD4 count, irrespective whether they are children or adults. When you can defer ART initiation is ಯಾರಿಗೆ ನೀವು ಲೇಟಾಗಿ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಬೋದು ಅಂದರೆ ವೆನ್ ಯು ಆರ್ ಸಸ್ಪೆಕ್ಟಿಂಗ್ ಮೆನಿಂಜೈಟಿಸ್ ಆರ್ ಎನಿ ಆಪರ್ಚುನಿಸ್ಟಿಕ್ ಇನ್ಫೆಕ್ಷನ್. So you can start after initiating ATT or other specific treatment. Okay, and adapted adherence support. So tailored counseling. So you should always counsel these patients to optimal adherence to the advanced disease package. If possible, nimmal ಸಾಧ್ಯತೆಗಳಿದ್ರೆ home visit is also advised, especially in individuals less than 200 CD4 count. It is applicable for both adults and children. So this is again a busy table which actually explains what is a flow chart for a patient living with HIV for advanced disease management. So now in further slides I will elaborate this in detail. So any patient who comes to ART center, okay, and you based on the definition you fit that patient for advanced HIV disease. So what you are supposed to do? The care coordinator will do a 4 symptoms TB screening. Then the patient further goes to the counselor, where a patient living with HIV with any of the following: child less than 5 years, not started on ART, any symptoms of cough, fever, weight loss, poor weight gain, night sweats, headache, difficulty breathing, chest pain, hemoptysis, paralysis, or seizures should be asked for, and CD4 less than 200, viral load more than 1000 copies per ml. So ಇದನ್ನೆಲ್ಲ ಗಮನಿಸಿದಾಗ what you should do is you should screen the patient for 4S TB screening, which will be done by a trained nurse, and ask for current symptoms of cough, fever, weight loss, poor weight gain, night sweats, difficulty in breathing, chest pain, hemoptysis, headache, unable to walk unaided, paralysis, seizures, ಏನಾದರೂ ಸಿಂಪ್ಟಮ್ಸ್ ಇದೆಯಾ ಅಂತ ನೀವು ಪೇಷಂಟ್ನ ಕೇಳಬೇಕು. ಅದಾದಮೇಲೆ ನೀವು ಅಸೆಸ್ ಮಾಡಬೇಕು ಏನಾದರೂ ಡೇಂಜರ್ ಸೈನ್ಸ್ ಆಫ್ ಸೀರಿಯಸ್ ಇಲ್ನೆಸ್ ಇದೆಯಾ ಅಂತ. ಲೈಕ್ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್, ಟೆಂಪ್ರೇಚರ್ ಇಸ್ ಮೋರ್ ದೆನ್ 39 ಡಿಗ್ರಿ ವಿತ್ ಹೆಡೇಕ್. ಇಫ್ ದ ಪೇಷಂಟ್ ಏನಾದರೂ ಹೆವಿ ಬ್ರೀದಿಂಗ್ ಮಾಡ್ತಿದ್ರೆ ಮೋರ್ ದೆನ್ 30 cycles per minute, ಇಫ್ ದೆರ್ ಇಸ್ ಮೋರ್ ಹಾರ್ಟ್ ರೇಟ್, ಟೆಕಿಕಾರ್ಡಿಯಾ ಇಸ್ ದೇರ್ ಮೋರ್ ದೆನ್ 120 beats per minute, ಅಂಡ್ ಪಲ್ಸ್ ಆಕ್ಸಿಮೀಟರ್ ಅಲ್ಲಿ ಸ್ಯಾಚುರೇಷನ್ ಕಡಿಮೆ ತೋರಿಸ್ತಿದ್ರೆ, ದೀಸ್ ಆರ್ ಆಲ್ ಕನ್ಸಿಡರ್ಡ್ ಸೈನ್ಸ್ ಆಫ್ ಸೀರಿಯಸ್ ಇಲ್ನೆಸ್. So then you refer the patient to the medical officer, where again the medical officer will do 4S TB screening, screen for persistent headache, other serious signs and symptoms. And what he will do is he will confirm these signs, and also he will assess ಅವರು ಅದೆಲ್ಲ ಸೈನ್ಸ್ ಇದೆಯಾ ಅಂತ ಕನ್ಫರ್ಮ್ ಮಾಡ್ತಾರೆ. ಮತ್ತೆ ಎನಿ ಸೈನ್ಸ್ ಆಫ್ ಕ್ರೇನಿಯಲ್ ನರ್ವ್ ಇನ್ವಾಲ್ವ್ಮೆಂಟ್ ಏನಾದರೂ ಇದ್ರೆ ಚೆಕ್ ಮಾಡ್ತಾರೆ, and he will confirm advanced HIV disease. So if there are any of this being positive signs of serious illness, any cranial nerve involvement, any focal neurological disease, what he should do is he should refer to the specialist. Or if it is to a lower center, you can refer them to the higher center. So ನೀವು ART centers ಇಂದ ನೀವು ART plus centers refer ಮಾಡ್ಬೋದು, or COE ಗೆ refer ಮಾಡ್ಬೋದು when you notice any of these serious illness signs and this thing. Confirm HIV, advanced HIV by doing CD4 count or WHO staging or child less than 5 years. If you confirm that HIV is there, advanced HIV disease is there, what you are supposed to do is screen, diagnose and treatment of opportunistic infection, screen for TB as I already discussed, do a CBNAT, chest X-ray and other tests. Same day serum CRAG should be done as a screening test for cryptococcal infection. Rapid CPT initiation in new case, co-trimoxazole prophylaxis, TB preventive therapy in absence of active TB, rapid ART initiation in new cases, intensive counseling to follow. If no, provide standard package of care so that you can do. Okay, so any patient walking to you, screen them for infection, screen them for serious illness. If you find serious illness, confirm, will be confirmed by a medical officer. So based on the condition of the patient, they will assess whether they should be referring to higher center, and also they will do investigations like CD4, and they will assess if the patient has any WHO stage 3, stage 4 illness, or if the child is less than 5 years. Based on this, if any of these criteria is fitting, they will go for advanced disease management package. If no, they will go for a standard disease management package. Okay, so based on the flowchart, it is able to easy to understand the advanced disease management package. So what is this patient management under? It's the same thing. So how do we screen and how do we track? So screen all patients who come to your ART. ನಿಮ್ಮ ARTಗೆ ಯಾರ್ಯಾರು ಬರ್ತಾರೋ ಅವ್ರಿಗೆಲ್ಲರಿಗೂ ನೀವು ಅಡ್ವಾನ್ಸ್ HIV ಡಿಸೀಸ್ನ ಸ್ಕ್ರೀನ್ ಮಾಡಬೇಕು. So as I already discussed in the previous slide, 4S screening ಜೊತೆಗೆ you should look for serious illness. Any of this is there, like temperature, more respiratory rate, less saturation, more heart rate, or if any of the following: unable to walk, unaided, altered sensory, seizure, paralysis, difficulty in talking, rapid deterioration of vision, signs of cranial involvement. So medical officers should always confirm this serious illness, and they will take an appropriate care by referring the patient to a tertiary care or higher center. In the absence of signs of serious illness, further assessment if required for evaluation of other components to be done. Okay, so this is the same thing what I explained in the previous slide. So now I was talking about screening. So how do we screen for TB? So TB is already previous slides ಅಲ್ಲಿ ನಾನು ತೋರಿಸ್ದಂಗೆ TB is the cause for mortality in patients with advanced HIV disease. So TB we should screen. ಬಂದವರಿಗೆಲ್ಲ TB screen ಮಾಡಲೇಬೇಕು. How are we going to screen? So diagnosis of TB becomes difficult as the immunosuppression worsens. So immunosuppression andre advanced stage ಗೆ ಹೋಗ್ತಿದಂಗೆ diagnosis of TB also will be difficult. So ಏನು ಮಾಡಬೇಕು? And also the spectrum of extrapulmonary manifestations also increases as CD4 count falls. So ART initiation should be done in all patients with TB regardless of CD4 count. But what is the timing of ART initiation is important. So when HIV TB co-infection is there, ART should be started as soon as possible within 2 weeks of initiating TB treatment, regardless of CD4 count among patients living with HIV. Whereas in patients with HIV with TB meningitis, so TB meningitis, ಬೇರೆಲ್ಲ TBಗೆ you can start within 2 weeks. ART after starting ATT, first ATT start ಮಾಡಬೇಕು, within 2 weeks ಅಲ್ಲಿ ART start ಮಾಡಬೇಕು. If it is TB meningitis, ಅಂದ್ರೆ brain infection because of TB, then ART should be started after 4 weeks of starting ATT. So corticosteroids is given in TB meningitis. Okay, so HIV TB co-infection ಏನಾದರೂ ನೀವು diagnose ಮಾಡಿದ್ರೆ, so ART should be started within 2 weeks of TB infection and ATT initiation. ಏನಾದರೂ TB meningitis ಇದ್ರೆ you should take at least 4 weeks to initiate the ART. So how do we assess for symptoms of meningitis? So meningitis is the brain infection. So how do you assess the involvement of brain? So patient will have fever, severe headache, chronic headache, altered mental status, and other neurological problem. Patient ಗೆ seizure ಇರ್ಬೋದು, one side body weakness ಇರ್ಬೋದು, difficulty in talking, rapid deterioration of vision, unable to walk unaided. So cryptococcal disease is an opportunistic infection which is also seen in advanced HIV disease. So most common presentation of cryptococcal disease is cryptococcal meningitis. So cryptococcus organism can cause meningitis in patients especially with advanced HIV disease. So why cryptococcal meningitis is important is it is a serious manifestation, major cause of morbidity, mortality among patients with HIV. So it's a serious, since it is involving the brain and causing meningitis. So it is a serious disease or serious manifestation. So what about prophylaxis? So now we saw how do we screen individuals based on symptoms and few tests. Now what is this prophylaxis? So co-trimoxazole prophylaxis is to prevent severe bacterial infection and pneumocystis carinii pneumonia. So ಯಾರ್ಯಾರಿಗೆ co-trimoxazole ಕೊಡ್ತೀವಿ ನಮ್ಗೆ ಆಲ್ರೆಡಿ ಗೊತ್ತಿರೋ ಹಾಗೆ all HIV patients with CD4 count less than 350 or HIV patients with WHO stage 3 stage 4 disease. ಸೊ ಯಾರಲ್ಲಿ ನಾವು ಐಸೋನಿಯಾಸಿಡ್ ಪ್ರೊಫಿಲಾಕ್ಸಿಸ್ ಥೆರಪಿ ಕೊಡ್ತೀವಿ. ಸೊ ಐಸೋನಿಯಾಸಿಡ್ ಪ್ರೊಫಿಲಾಕ್ಸಿಸ್ ಥೆರಪಿ ಶುಡ್ ಬಿ ಗಿವನ್ ಇನ್ HIV patients who do not have 4S symptoms and who do not have active TB. Why we are giving ಯಾಕೆ ಕೊಡ್ತಾ ಇದ್ದೀವಿ ಅಂದರೆ ಟು ಪ್ರಿವೆಂಟ್ ಲೇಟೆಂಟ್ TB ಟು ಗೆಟಿಂಗ್ ಕನ್ವರ್ಟೆಡ್ ಟು ಆಕ್ಟಿವ್ TB. ಫ್ಲುಕೋನೋಸೋಲ್ ಯಾರಲ್ಲಿ ಕೊಡ್ತೀವಿ ಅಂದರೆ ಇಂಡಿವಿಜುವಲ್ಸ್ ವಿತ್ cryptococcal meningitis. If cracked antigen in serum is positive without evidence of meningitis, you can give fluconazole. Or fluconazole primary prophylaxis can be directly started if CD4 is less than 100 without evidence of crack screening testing. So normally crack screening testing ಮಾಡಲ್ಲ. So ಅದಕ್ಕೆ anybody with CD4 count less than 100, you can directly give fluconazole primary prophylaxis. So co-trimoxazole prophylaxis ಬಂದು less than 350 CD4 or any WHO 3-4 stage. IPT prophylaxis ಬಂದು no symptoms of TB, who do not have active TB evidence, you can start IPT prophylaxis. Fluconazole prophylaxis ಬಂದು, since we don't do crack screening, anybody with CD4 count less than 100, you can start with fluconazole prophylaxis. So why we are talking more about adherence support? Because these patients are known to be poorly adhered to the medications. Why? Because the frequency of medication is more, pill burden is more, drug interactions are more, side effects of these medications are more, poor morale, travel cost and expenses. So these are all the challenges. How do we overcome these challenges? ಹೆಂಗೆ ನಾವು ಇದು ಮಾಡ್ಬೋದು ಅಂದ್ರೆ ಒಂದು counseling. So every RT center, what we advise is proper counseling, intensified adherence support, outreach through CSC, peer support, treatment supporter and treatment literacy. So patient ಗೆ counseling ಮಾಡಬೇಕಾದ್ರೆ we should talk about the treatment options, why we need this treatment, and also intensified adherence counseling has to be done, especially individuals who default and come. So you can also do outreach programs, and also you should, ask them to take peer support and treatment supporter. Educate them about the treatment. So complicated cases you should always refer. ನಿಮಗೆ ಏನೇ complicated case ಅನ್ಸಿದ್ರು refer to ART plus center or COE. Most of the cases can be managed as indoor patients. One patient stabilized, ensure communication for referral back to the parent ART center after discharge for continuation of ART or OI medication as indicated. So once ನೀವೇನಾದ್ರು refer ಮಾಡಿದ್ಮೇಲೆ ತಿರ್ಗಾ patient ನ you have to follow up. It should be done by the parent ART center only. So they should also be linked to appropriate differentiated care services under the program to facilitate retention in care and ensure good treatment adherence. So rapid initiation of ART is very important. ನಾವು ಎಷ್ಟು ಬೇಗ ಸಾಧ್ಯ ಆಗುತ್ತೋ ಅಷ್ಟು ಬೇಗ ART initiate ಮಾಡಬೇಕು. So as soon as you confirm, initiate ART. Rapid initiation andre ಏನು? Within 7 days of HIV diagnosis, you are supposed to initiate ART. This is especially important in individuals with advanced disease program. So it is very important in patients who have advanced disease. ART initiation should be offered on the same day to people who are ready to start. So what is the evidence? Why they are telling Vega start Madi ART within 7 days you should start? Because it is shown that all these studies which are over here, it is shown that the mortality will be reduced and clinical outcome will be better if you start ART early, that is within 90 days. Okay, so that's why we are giving importance to early initiation of ART unless contraindicated. So rapid ART initiation to ensure timely ART initiation in patient living with HIV and child living with HIV. People with no contraindication to ART, rapid ART initiation should be fully informed about the benefits of ART, should be offered rapid ART initiation within 7 days, ART initiation after preparedness counseling, including the option of same day initiation. People with very low CD4 count, rapid ART initiation is extremely important. Child living with ART also, rapid initiation is very, very important. People who have no clinical signs and symptoms of TB and other OIs, whose CRAC test is negative, there also you can initiate ART along with prophylaxis. Okay. So that is why we give importance to rapid. So ಎಷ್ಟು ಬೇಗ ಸಾಧ್ಯತೆ ಆಗುತ್ತೋ within 7 days, register the patient and start ART unless it is contraindicated. So what is this intensified tailored counseling support for people with advanced disease? So people with advanced HIV require closer follow-up during the initial period of receiving ART to monitor the response to ART and identify signs and symptoms of possible IRIS. So ಯಾರಿಗೆ ನೀವು ART initiate ಮಾಡಿರ್ತಾರೆ, especially in advanced HIV disease, ನೀವು ಅವ್ರಿಗೆ ಫಾಲೋ ಅಪ್ ಮಾಡಬೇಕು. ವೈ ಫಾಲೋ ಅಪ್? ಬಿಕಾಸ್ ಯು ಐ ಐಡೆಂಟಿಫೈ ದ ರೆಸ್ಪಾನ್ಸ್ ಟು ಟ್ರೀಟ್ಮೆಂಟ್ and also any occurrence of IRIS. We all know that low CD4 count, presence of opportunistic infection, high risk of IRIS. So you should follow them up. People missing appointment should be rapidly traced by phone or through home visit. Where face-to-face contact is not feasible, distant contact through telephone, consultation, mHealth, text message or mobile interventions, or visit through a community health worker or home-based caregiver should be considered with consent of the client. ART staff should to familiarize themselves to new counseling messages around rapid ART initiation, viral load monitoring, differentiated care, especially advanced disease management. So that should be important. So ART staff should know what is the importance of rapid ART initiation, viral load monitoring, differentiated care, especially in patients with advanced disease management. So next is opportunistic infection prevention. So first is primary prevention, next is secondary prevention. Primary prevention ಅಂದ್ರೆ ಯಾರಿಗೆ ಇನ್ಫೆಕ್ಷನ್ ಆಗಿರಲ್ಲ, ಇನ್ಫೆಕ್ಷನ್ ಆಗದೇ ಇರೋ ಥರ ತಡೆಯೋದಕ್ಕೆ we give primary prevention. Secondary prevention is already ಇನ್ಫೆಕ್ಟ್ ಆಗಿರ್ತಾರೆ, ಫರ್ದರ್ ಇನ್ಫೆಕ್ಟ್ ಆಗದೇ ಇರೋದನ್ನ ಸೆಕೆಂಡರಿ ಪ್ರಿವೆನ್ಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಸೊ PCP ನ್ಯೂಮೋನಿಯಾಗೆ ಡ್ರಗ್ ಆಫ್ ಚಾಯ್ಸ್ ಇಸ್ ಕೋಟ್ರೈಮಾಕ್ಸಿಲ್, TBಗೆ ಐಸೋನಿಯಾಸಿಡ್, ಕ್ರಿಪ್ಟೋಕಾಕಲ್ ಇನ್ಫೆಕ್ಷನ್ it is fluconazole. Whereas secondary prevention of PCP, cotrimoxazole, TB, isoniazid, cryptococcal is again fluconazole. So what is cotrimoxazole prophylactic therapy? So we should start, as I already told earlier, anybody CD4 less than 350 or WHO class 3, class 4 disease. Timing the initiation of cotrimoxazole in relation to ART. First, always start prophylaxis. Start ART after starting cotrimoxazole. As soon as CPT is tolerated, the patient has completed the preparedness phase of counseling. So first cotrimoxazole start ಮಾಡಿ ಆಮೇಲೆ ART initiate ಮಾಡಬೇಕು. So whom do you um, successfully completed treatment until CD4 count? So secondary cotrimoxazole therapy ಯಾರು ಕೊಡ್ತೀರಾ in individuals with PCP pneumonia. So whom after PCP pneumonia treatment, you should give them secondary cotrimoxazole prophylaxis therapy until CD4 count is more than 350, at least on two occasions. Two occasions ಅಲ್ಲಿ more than 350 ಇರಬೇಕು, which is done 6 months apart. What is the dose that we give? One double strength tablet or two single strength tablet, which is total of 960 mg, 800 mg of sulfamethoxazole, 160 mg of trimethoprim. So cotrimoxazole in pregnancy and breastfeeding, it is indicated both in pregnancy and breastfeeding. So patient yaar allergy irtare, that time you can give dapsone 100 mg per day, but cotrimoxazole desensitization also can be done. You should attempt that, except if the patient has very severe reaction. In them, you should not attempt cotrimoxazole desensitization. How do we monitor? There is no specific laboratory test to monitor. When do you discontinue? ಯಾವಾಗ ನೀವು ಸ್ಟಾಪ್ ಮಾಡ್ಬೋದು ಅಂದರೆ CD4 on monitoring if it is more than 350 on two occasions. So ಎರಡು ಸತಿ ಟೆಸ್ಟ್ ಮಾಡಿದಾಗ more than 250, 350, which is 6 months apart, and also with an ascending trend and devoid of any WHO class 3, class 4 disease, stage 3, stage 4 disease. So when do you restart cotrimoxazole? So when you restart, already you've initiated, you've stopped because CD4 count has gone up. Patient has not having any stage 3, stage 4 disease. So when do you restart? Restart will be done when CD4 falls again less than 350 because of ART failure, any other immunosuppressive condition, or any immunosuppressive drugs. So in such patients, you should restart cotrimoxazole immediately until CD4 is more than 350 on two occasions, or ascending with an ascending trend and devoid of any WHO clinical stage 3, stage 4 condition. So as we said, desensitization is done in individuals who are allergic. ಯಾರಿಗೆ allergy ಇರುತ್ತೆ to cotrimoxazole, you can desensitize. So day one, you can give 80 mg of sulfamethoxazole and 60 mg of trimethoprim. See, there is something called cotrimoxazole oral suspension, which has 200 mg of sulfamethoxazole and trimethoprim of 40 mg per 5 ml. So 2 ml on day 1, 4 ml on day 2, day 3 6 ml, day 4 8 ml, day 5 single strength tablet you will give, day 6 double strength tablet can be given. So if there is no reaction, you can continue cotrimoxazole. If there is severe allergic reaction, you can stop and start dapsone. So in children, whom do you give CPT? All HIV exposed infants and children from 6 weeks of age. HIV infection has been reliably excluded by a negative antibody test at 18 months regardless of ARV initiation. All HIV infected infants and children up to 5 years of age, regardless of WHO stage or CD4 counts. At 5 years of age, when clinical or immunological indicator confirmed restoration of immune system for more than 6 months in a child more than 5 years of age with a WHO stage 1 or 2 or CD4 more than the 350, both two occasions not less than 6 months apart. So you can discontinue the cotrimoxazole prophylaxis therapy. Okay, so children, you should start, all HIV exposed children, you should start cotrimoxazole prophylaxis therapy. Infants, you should start after 6 weeks of age. So when you can stop, based on again a negative test or ARV initiation. If it is more than 5 years of age, if it is 5 years of age, then you can stop it in individual more than 5 years with stage 1 or 2 WHO, CD4 more than 350 on two occasions. If the child is more than 5 years, you start when same like adult, 350 CD4 less than 350, WHO stage 3-4 regardless of CD4 count. So when will you discontinue? If the child is more than 5 years with WHO stage 1, stage 2 and CD4 more than 350, 6 months apart. So secondary prophylaxis after completion of treatment for PCP, less than 5 years do not stop, more than 5 years, same WHO stage 1 and 2 or CD4 more than 350 with 6 months apart. So cryptococcal disease. So how do we diagnose cryptococcal disease? We do a lumbar puncture and see for culture, microscopy and detection of cryptococcal antigen. So if cryptococcal disease is confirmed by identification of cryptococcus in CNS or CSF. So serum crag is usually positive in both meningeal and non-meningeal infection. Serum crag may be present weeks to months. So serum cryptococcal antigen ನೀವೇನೋ ಟೆಸ್ಟ್ ಮಾಡಿದ್ರೆ weeks to months before onset of symptoms, it will be positive. A positive serum crack should prompt a lumbar puncture to rule out meningeal disease. So, ಯಾರಲ್ಲಿ serum crack positive ಬಂದಿರುತ್ತೆ ಅವರಲ್ಲಿ you should always do a lumbar puncture and confirm meningeal disease. So, primary prophylaxis can be given in case of crack test is not available. You should give it when the CD4 is less than 100. Dosage is fluconazole 100 mg OD. Criteria for discontinuation: if all the following is there, you can discontinue. Patient adherent to ART, free of cryptococcal disease, given for at least fluconazole should be given at least 1 year, CD4 more than 100, suppressed plasma viral load less than 1000 copies. So all should be there to stop fluconazole. So once you have started prophylaxis, you should see for all this and then stop based on the criteria. Secondary prophylaxis is after 2 weeks of successful treatment for cryptococcal disease and 8 weeks of consolidation phase with fluconazole. You can give dosage of 200 mg daily for adults or 6 mg per kg per day in children. So criteria to discontinue same. Patient adherent to ART and free of infection. Fluconazole given for at least 1 year. CD4 more than 100. Plasma viral load less than 1000. So that is about prophylaxis in cryptococcal infection for fluconazole. Yeah, so I think I've covered most of it. In brief, it is very important ನಮ್ಮ ಎಲ್ಲ ART centers, ART sub centers, whatever we have, ಐಡೆಂಟಿಫೈ ನೀವು ಏನು ಮಾಡಬೇಕು ಅಂದರೆ ಪೇಷಂಟ್ನ ಐಡೆಂಟಿಫೈ ಮಾಡಬೇಕು. ಯಾರು ಅಡ್ವಾನ್ಸ್ಡ್ HIV ಡಿಸೀಸ್ ಇದ್ದಾರೆ ಅವರಲ್ಲಿ ಸಿಂಪ್ಟಮ್ ಸ್ಕ್ರೀನಿಂಗ್ ಮಾಡಬೇಕು. ಸಿಂಪ್ಟಮ್ ಸ್ಕ್ರೀನಿಂಗ್ ಮಾಡಿ CD4 WHO ಸ್ಟೇಜ್ 3 ಸ್ಟೇಜ್ 4 ಡಿಸೀಸ್ ಇದೆ ಅಂತ ಚೆಕ್ ಮಾಡಿ ಆ್ಯಂಡ್ ದೆನ್ ಯು ಶುಡ್ see if they have any active infection. If there is active infection, you should treat active infection, simultaneously start ART unless it is contraindicated, especially in TB meningitis. If there is no active infection, you can straight away start ART. Very early initiation is what is important. And prophylaxis. Prophylaxis, we have three things. One is fluconazole prophylaxis for cryptococcal meningitis, cotrimoxazole prophylaxis for PCP and bacterial infection, isoniazid prophylaxis for TB. So all these three things you should know along with ART initiation.
Thank you so much, sir, for facilitating this important session. We have one question in the chat box. Now that we are doing tennis TB screening and CY TB test, does it apply to ADM as well?
Yeah, recent guidelines. Yeah, it is. It is there in the recent guidelines.
Right. Any other questions? Kiran sir, can we please give mic access to everyone? Requesting participants to please unmute and ask questions. Any questions regarding advanced disease management? Please feel free to unmute and ask questions.
Excuse me, sir.
Yes, ma'am.
We have seen that whenever there is a low CD4 count, mainly patients come in respiratory distress and unconscious states. And that time, TB, apart from TB meningitis and also meningitis, there may be other viral and bacterial meningitis also. And advanced disease package, we have to consider CSF testing for all organisms. Sir.
Okay, ma'am. See, ನಿಮ್ಮಲ್ಲಿ ಏನಾದ್ರೂ if you have facility for CSF testing, so we should do a general CSF evaluation like protein, sugar, cell count, cell type, and also based on the clinical presentation, We should also suspect viral, bacterial, tubercular, since the patient is immunosuppressed. So we should also suspect fungal, that is cryptococcal also. So we should suspect common organism also, and also since he is immunocompromised, we should suspect cryptococcal TB also in that patient.
Okay. Thank
It
you.
is not different from general population. It is same as general population, but additionally you should consider
Okay.
fungal and TB.
Okay. So CSF culture and sensitivity can be done for drug
Yes, it
sensitivity.
should be done. It should be done for all
Okay.
patients.
Thank you.
Also, we have one question in the chat box. Can you please explain the relationship between CD4 and viral load?
See, CD4 and viral load. See, as the viral load increases, CD4 tend to drop. Although we in NACO we have viral failure, immunological failure, clinical failure. So that's why we give importance to CD4 and WHO stage 3, stage 4 diseases also, even we are talking about advanced HIV disease. So CD4 is an immunological marker of HIV, whereas viral load is a viral marker of HIV disease progression. And when we come to clinically, if you have to assess HIV disease progression, we have clinical markers based on WHO staging.
Good afternoon, sir.
Yeah, good afternoon.
Sir, why I am asking this question is many times we have come across even though viral load is TNT, CD4 count is decreased.
See that there can be some discordance also. So
Any
viral
other
load.
disease can cause the CD4 decrease when viral load is normal.
Yeah, that's what can be a discordance between the viral load and CD4 count. That can also happen in some instance. The percentage is quite less, but that can also happen. That we call it as discordance, when there is a discordance between the CD4 and the viral load. As you said, there is no relationship between the viral load, but the CD4, the viral load will be not detectable, but the CD4 will be low. So that also is possible. But so when we are considering advanced disease, so we want to simplify, we have kept only with CD4 and clinical staging.
Any immunological disorders that can cause a decrease in
Yeah, any primary immunological disorders which affect the T cell immunity can cause
decrease
low
in
CD4 count. Yeah, it can cause. We have panel. See, if in that case, if you want to, evaluate the patient, you can refer them to like higher centers where they actually do the testing for all this panel.
oh, that's it.
Yeah. Okay.
Any more questions? So we'll quickly run the feedback poll. Kiran sir, can we please have the feedback poll? Thank you. The feedback poll is now visible on your screen. All the participants are requested to please attempt the feedback poll. There are 5 questions in all. Scroll through them, click on the answer of your choice, read the last question carefully. Requesting all participants to please attempt the feedback poll before they leave the meeting. Kiran sir, we can end the feedback poll now. Thank you to all the participants for patient listening. Thank you once again, sir, for your time to facilitate this session. Thank you, everyone. We'll conclude the session now.
Shweta sir has left some
Yes.
emergency cases
Okay.
come.
Okay. No problem. No problem, ma'am. Thank you so much, ma'am.
Okay, thank you, Shweta.
Bye, ma'am.